Hi, everyone, and welcome back to Fit for Fellowship, a survival guide for the first-year general cardiology fellow. I'm Megan Pelter.
And I'm Stacy Tsai. And today we have Dr. Herr from California Pacific Medical Center, CPMC, who's going to give us a talk about troubleshooting temporary mechanical circulatory support. So Dr. Herr is an assistant professor of medicine at the Dartmouth Geisel School of Medicine and the program director for the California Pacific Medical Center Advanced Heart Failure and Transplant Cardiology Fellowship. In addition, he is director of continuing medical education at the Palo Alto Medical Foundation and a member of the CPMC Cardiology Fellowship Clinical Competence and Recruitment Committees. Dr. Herr specializes in advanced heart failure and transplant cardiology. He received his medical degree from University of Texas Medical Branch at Galveston School of Medicine and completed his internal medicine residency at the University of California, San Francisco. He completed fellowships in cardiovascular disease and advanced heart failure and transplant at the Cedars-Sinai Schmidt Heart Institute. So let's go ahead and move on to Dr. Herr's talk.
Welcome, everybody, and thanks for joining us today for our next installment of the California ACC Fellow and Training Curriculum. My name is Herr, and I am the Program Director of the CPMC Advanced Heart Failure and Transplant Cardiology Fellowship here in San Francisco. And I am delighted to have an opportunity to talk to you about the management of temporary mechanical circulatory support in the CCU. As an overview of today's talk, we're going to talk about the goals of temporary mechanical circulatory support devices in treating shock. We'll specifically talk about intra-aortic balloon pumps. We'll talk about temporary ventricular assist devices, such as the Impella and Tandem heart device. And we'll also go over some basics of VA ECMO. So what are the overall goals of MCS devices in treating cardiogenic shock? We know that inotrope and vasopressor use and dose escalation is associated with increase in mortality. And so one of the goals of using MCS devices is to try to minimize the doses of inotropes and vasopressors. Their goal is to provide adequate circulatory support and systemic perfusion for the patient who's in shock or needs extra help. Also to provide favorable hemodynamic optimization, such as decreasing left ventricular preload and afterload. Also, they increase coronary perfusion pressure through an increase in diastolic blood pressure and or a decrease in the LV and diastolic pressure. The first device that we're going to talk about is also the one that's been around the longest, and that's the intra-aortic balloon pump. It was been used clinically since 1967, and it provides counterpulsation to the patient. It is inserted into the descending thoracic aorta, typically by the femoral artery, although you may see axillary cannulation as well. It inflates immediately after aortic valve closure and deflates just before aortic valve opening. It comes in varying sizes from 20 to 50 cc's, depending upon the size of your patient. And timing of the balloon cycle is based on EKG and aortic pressure measurements. It is utilized in acute coronary syndrome for increased perfusion pressure. It's used in mitral regurgitation for reduction in afterload, and also used in cardiogenic shock for all of the above reasons. This is a typical chest X-ray of a patient with a balloon pump, and I just called your attention to the tip of the balloon pump because this is an important thing to take a look at every day on your patients, or at least several times a week, and check the position of the pump. The tip of the balloon pump, which is there in the red circle, should be somewhere around the carina and towards the aortic knob. But you want to make sure that the pump is not too high or too low, which may cause problems with other vascular territories in that area. Balloon pumps have many favorable hemodynamic effects. They reduce systolic blood pressure. They reduce left ventricular and diastolic pressure. They reduce LV afterload. And they also increase coronary perfusion because they increase the diastolic blood pressure. All of these things lead to a reduction in myocardial oxygen demand and an increase in the cardiac output for the patient. Some management considerations related to balloon pumps. The first thing being, do they need anticoagulation? So when a balloon pump is at one-to-one augmentation, meaning that the balloon is inflating, deflating with every cardiac beat, there doesn't necessarily need to be anticoagulation for the patient, given the fact that there's not a lot of time there for thrombi to form on the pump itself. But if you're less than one-to-one augmentation, we suggest that you would use systemic anticoagulation such as heparin in that scenario, as long as there's no contraindication. Embolic phenomenon can happen with balloon pumps, again, because thrombi might form on the pump itself as it inflates and deflates, or you may have issues with atherosclerosis in the aorta or at the femoral insertion site. Not uncommonly are vascular access complications. This can occur at the time of device removal. You may have vascular injury or even limb ischemia, especially if you have a small patient or those who have significant PVD. There may be an obstruction of blood flow due to the size of the catheter in the distal portion of the limb. Also commonly, hemolysis and thrombocytopenia may occur. This is because of mechanical destruction of the red blood cells and platelets, and this can lead to issues with bleeding or elevated bilirubins. Positional issues with the pump, again, thinking back to that chest x-ray that we just looked at, if the pump is too high, you can imagine that you might obstruct the carotid or subclavian artery, which will cause a lot of problems. And if it's too low, it may obstruct the renal artery and cause renal failure. So it's very important to make sure that you check the position on a regular basis. The next thing that's important to recognize, again, is to be able to interrogate the aortic pressure waveform of a balloon pump assisted patient. You're going to see these waveforms on the control panel of the device, and I'll just walk you through what we're looking at here. And so this particular device is set at 2:1 and is used to illustrate kind of the difference between an assisted and unassisted beat. The first thing that we see here is the unassisted systolic pressure. Then you have inflation of the balloon, which occurs at the dicrotic notch, right? When the aortic valve is closed, you have an augmented diastolic pressure, which is high. There's increases above the systolic pressure. And then you have the assisted end diastolic pressure that occurs when the balloon deflates, and you see that that's low. And then looking at the unassisted beat, this again is the assisted systolic beat. They call it the next beat, systolic pressure, excuse me. And that's generally the same as unassisted. But the unassisted end diastolic pressure is quite a bit higher than the assisted end diastolic pressure, therefore indicating a lowering of the LVEDP. Now, these waveforms can look funny, and it's important for us to get some pattern recognition as physicians in regarding sort of the errors that may occur with either inflation or deflation of the balloon and what that might look like on a waveform. So early inflation, which we have here on the left, is when the balloon inflates before the closure of the aortic valve. So remember, the dicrotic notch is at the time that the aortic valve closes, and you see here we sort of lost the dicrotic notch. And what happens there is you have an increase in oxygen demand. Because of that, you have increase in myocardial stress, and you get less benefit from the pump itself. Also with late inflation, this happens after the aortic valve is already closed. And that basically lowers your peak diastolic pressure, so you're getting less augmentation, and also your assisted systolic beat goes down as well. And what you see here is basically sort of this W formation. So you just remember the W being late inflation. Now, the pump can also have issues with deflation, right? Either early or too late. And if the pump is deflating too early, as it is here on the left, again, you sort of have this U shape in the waveform here between the assisted and unassisted beats. And what happens there is you have no reduction in afterload, basically, and no reduction in oxygen consumption. So you're basically not getting any kind of assistance there as well. In terms of late deflation, again, you see the peak systolic pressure exceeds the assisted peak systolic pressure, and that leads to the LV having to eject against inflated balloon, and therefore it has an increase in myocardial oxygen demand, and does not improve the patient. So what are the contraindications to balloon pump placement? One being significant aortic regurgitation. Again, if the balloon is inflating and the aortic valve is leaking, you're going to cause increased regurgitation of the valve as well. Aortic dissection or clinically significant aneurysms are contraindications as well, because you don't either want to cause a dissection or get into a false lumen or propagate a dissection. Patients with uncontrolled sepsis or uncontrolled bleeding disorders, again, can cause issues with the pump due to the need for anticoagulation or hypotension. And then again, severe peripheral vascular disease is also an issue, leading to limb ischemia. But overall, balloon pumps are very common. You'll see them on a regular basis in the ICU. They're very easily put in the cath lab and or at bedside, could even be placed during a code. So moving on, we'll talk about the Transaortic Micro-Axial Flow device, or LVAD, which is also known as an Impella. The Impella is a microaxial flow pump that sits across the aortic valve in the left ventricular cavity. It has an inlet area and an outlet area, and it basically takes blood from the left ventricle, pumps it through the motor, and delivers blood into the ascending aorta. These come in several different sizes. The ones that we'll really talk about today are the Impella 5.5 and the Impella CP. Nowadays, they have an optical sensor that helps with pump position and understanding aortic and ventricular waveforms. The main sort of pumps that you're going to come across, like I said, are the 5.5, which gives you up to about 6 liters of flow, but usually around 5.5 liters. It's a 9 French catheter, it's 21 French pump, and that needs to be placed surgically. The Impella CP can be placed in the cath lab from femoral access, and this can be done fairly quickly. Again, it is a 9 French catheter with a 14 French pump, so a smaller size device, but fundamentally has the same function as the 5.5. Impella can be inserted in multiple different places. So you can see here, you have femoral insertion, which again is typical placement for a CP. We have axillary insertion, which is typically the place that a 5.5 is implanted. That involves a cut down of the axillary graft, placing it through the axillary artery into the heart across the aortic valve. There's also a right ventricular assist device, which is called the Impella RP, and this is a device that is placed in the venous system that comes up through the right heart into the pulmonary artery, and the inflow area is in the IVC, and the outflow area being in the main pulmonary artery, therefore causing assistance to the right side of the heart. The device controller is what you're going to see when you walk in the room, and this gives you a lot of useful information. It's your interface for monitoring. It is where the purge fluid to the catheter is contained, and is also a backup system for power. So we'll look at the different waveforms on the console so you know what you're looking at when you walk into a patient's room. So this is just an example of what the Smart Assist devices now, the CP and the 5.5 Impellas waveforms look like. What you see here is the Impella flow rate. This is telling you about what the purge flow is, and we'll talk about what that is, the purge pressure, and again, another marker to look at. And then we have the placement signal and the motor current. Now, the placement signal, on the current devices is derived from an optical sensor. It displays a calculated waveform that's very useful to identify position. You should see, again, both a distal and a proximal waveform. So the proximal waveform should look like an aortic waveform because that's where near the outflow near the outflow of the pump, and then the distal portion should be a ventricular waveform, again, indicating that the pump is in the correct position. It should be pulsatile, and if it's flattened, then there's an issue with the differential pressure between the two. The motor current is the energy that is intake of the catheter, and it varies with motor speed and difference between the inlet and the outlet. It should be pulsatile, and that indicates that you're in the correct position because there should be a slight difference between the in and out. Some management considerations with the Impella. First, again, we'll talk a little bit about anticoagulation. We'll talk about mobility, which is a problem for the femoral axis. Patients can't get up and move around. And then again, like any kind of percutaneous device, you can have vascular access site injury as well. So Impella anticoagulation is made up of two different things. So first being the purge solution, and then also systemic heparin potentially. The purge flow is the rate of fluid that's delivered to the catheter from the purge cassette, which is in the controller. And it typically ranges 2 to 30 milliliters per hour. And the purge pressure, that's the pressure that moves the fluid through the catheter into the motor. And this is controlled automatically by the controller, and the typical range is between 300 and 1100 millimeters mercury. And then the purge infusion, it's a concentrated heparin drip, anywhere between 12.5 to 50 units per milliliter. Most of the time it's 12.5 to 25 typically. And you can calculate how much heparin that you're delivering to a patient based on the flow rate as well as the concentration. Now the flow rate is variable because it changes based on the purge flow and the purge pressure. And so what you can do is you can look at the infusion history to get an idea of what the overall heparin delivery dose is over the course of a certain period of time, to sort of have an understanding of how much heparin you're actually giving your patient. And this is important because if you're targeting specific anticoagulation goals, which typically are PTT 60 to 80, or a therapeutic 10A of 0.3 to 0.7, or some people will use ACT. You're going to want to know how much heparin a patient is getting, and then if you need to, stack on top of that systemic heparin or to meet your goals. Impellas unfortunately have a lot of complications also. There are a couple things that are really common. First thing to watch out for is aortic regurgitation. Again, you're going across the aortic valve and you can cause damage to that valve. This may also occur after the pump is taken out if it's used in a recovery situation. Hemolysis, probably the most common thing that you're going to see. And so typically you monitor patients with a daily LDH, at least initially, and then you can cut back on that until a couple times a week typically. But hemolysis is a big problem, especially with the smaller devices. It seems to be less of an issue, in my personal opinion, with a larger 5.5 device, but still happens. But hemolysis can lead to renal failure and anemia as well. You can also have stroke, again, because you have a mechanical device, and thrombi can form on that device as well. Mitral regurgitation, especially if the pump is in the incorrect position and it gets caught up in the subvalvular apparatus of the mitral valve, it may entangle it and cause MR. Again, vascular access injuries, common theme here, and bleeding. Obviously, you're on anticoagulation, and therefore that can increase your risk of bleeding. We're going to run through just a couple of clinical scenarios and talk about a couple of issues with managing Impellas. So first case is a 65-year-old male with ischemic cardiomyopathy. He came in with cardiogenic shock. He was stabilized initially with inotropic therapy and then transitioned to an Impella 5.5, which was set at P9, which is the highest setting. He's getting about 4.2 liters per minute. And he was doing fine. His MAP is in the 90s. His filling pressures look pretty good. His cardiac output was all right. So the decision was made at that time to start weaning his inotropes, and the inotropes were all weaned off. And then about 24 hours later on post-op day 3, the nurse calls you with a report of suction alarms and a low flow on the pump down to 1.8 liters per minute. The patient's hemodynamics have changed. His MAP had dropped from the 90s to the 70s. His RA pressure had increased from 5 to 15, and his PA pressure more or less stayed the same, except for his PA diastolic pressure dropped from 12 to 5. We also saw a subsequent decrease in his cardiac output with a drop in his mixed venous sat down to 45%. And so what happens with a suction alarm? What are the things that can cause that? And so basically suction alarms are related to sort of inadequate LV filling, right? And so either that means that the pump is in the wrong position. It may mean that the patient is hypovolemic. It also may mean that they have RV failure. And clinically, what we see is hypotension. You see a reduction in the mean motor current. It may cause a reduction in flow and increase your risk of hemolysis. And so what the first thing you want to do is sort of reduce the power level down to probably P2 to let the heart fill up a little bit. You want to check patients' YM status, see what their CVP looks like if they have a PA catheter or a swan or something. You want to check the position of the catheter with an echo. And then you also want to clinically look at someone's RV function. Now, in our prior case here, what we saw was an increase in right-sided filling pressures and a drop in blood pressure and a drop in cardiac output after we weaned off inotropes. And so those are clinical findings related to right ventricular failure. And so in this particular situation, what the patient would need is inotropic therapy to help improve right to left flow, and probably just needs a longer term wean of his inotropes. Now, our second scenario is a 75-year-old gentleman who had a history of chronic ischemic and valvular heart disease. He came in with acute and chronic heart failure, developed shock, and acute renal failure. Initially, a balloon pump was placed to stabilize the patient, and then he got transitioned to a 5.5 Impella also to allow for improvement prior to possible VAD placement. On post-op day 1, after Impella placement, the nurse calls you to the bedside for an abnormal waveform on the device monitor. And when you get there, this is what the device looks like. What we see here is that both of the waveforms look abnormal. The motor current has flattened out. And instead of seeing an aortic pressure and a ventricular pressure, you see two waveforms that basically look the same. And so the question is sort of, is the pump in the right position? And you can tell a lot from the current device's optical waveforms in terms of Impella position, but there are a few things to think about as we go through. So on the left, we see what an Impella looks like when it's completely in the LV, and that's the case of this particular patient. You have a predominant LV waveform in the placement signals, right? And the motor current, again, is dampened because there's not that difference between inflow and outflow. Now, the pump may also be completely in the aorta, and you would have, again, the opposite of that. You'd have a predominant aortic waveform, and again, the motor current would be dampened in that scenario as well. And so the first step in managing a patient like this is one, again, to reduce the P level to P2, and then do some imaging to try and reposition the pump. And we'll talk a little bit about the use of echocardiography and Impella for position placement. You may also get this kind of alarm, which says the Impella position is unknown. And typically this just means that, the Impella, there's not that much of a difference between LV and aortic pressures, right? And so that typically happens when there is a really low amplitude and a decrease in native pulsatility. So in patients whose hearts are really, really sick, you may actually have this particular issue. But if the patient's doing okay and the flow rate's all right and the Impella position on echo is all right, then there is not much to do about it besides monitor. So sometimes the chest X-ray can be helpful in taking a look at an Impella position. This was an unfortunate patient who came to us from an outside hospital. Was placed on VA ECMO out there with an Impella CP. When he came to us, he was being moved into the bed, and all of a sudden his pump starts to alarm. The quickest thing we could get was a chest X-ray, and that while the echo machine was coming, chest X-ray showed that the pump had been pulled basically all the way back into the aorta. So normally we would see the pump here in the LV, but what you see is the inflow and the outflow all the way in the aorta past the aortic valve. Echo is probably the most useful imaging technique in managing Impellas, and we'll talk about a few things in terms of how do you assess the position of an Impella based on echo. So the first thing is to know is just sort of what are we looking at? So this is a peristernal long axis view. So you have the posterior wall, left atrium, left ventricle, septum, RV, aortic valve. So here's your Impella pump. The distal portion of it is the inflow or inlet area. That should be sort of in the mid cavity of the LV, away from the papillary muscles and the chordae. And then there's a bend in the device, which should be at the aortic valve. And then you have the outflow area, which should be above the aortic valve in the ascending aorta. So you can measure the distance from the Impella catheter inlet to the aortic valve, and that should be about 5 centimeters or so. The catheter, again, should be angled toward the apex, away from the heart wall, and not curled up inside near the mitral apparatus. So here are some examples of abnormal placement of an Impella. So this is too distal, where you see that the pump is too close to the apex, and you see the bend here is beyond the aortic valve. And so that's actually in sort of almost in the middle of the cavity. That means the pump needs to be pulled back. In this scenario, you may see, again, predominantly LV waveforms on your controller. And you may also see that the pump is turned, and that means that it's pointed, sort of in this situation, posterior towards the papillary muscle. And so the inlet area gets sucked up inside this valvular apparatus and leads to pump malfunction, cause mitral regurgitation as well. And then it also causes the outlet to be too close to the aortic valve. And we see that the bend is past the aortic valve and sort of near the papillary muscle. Here's an example in real life of a patient whose pump is in too far. So we see this is the distal inlet area. Here's the pump housing. And then this is the bend part here. Now the aortic valve is in this area. So this patient's pump is too distal in this particular scenario, and this pump was pulled back. And whenever you're adjusting an Impella position, you should always reduce the pump speed to P2. Doppler echo can also be useful in determining position of the pump. Normally, we should see some turbulent flow in the ascending aorta or aortic root, and that's because that's where the outflow area is of the pump, but you shouldn't see it on both sides of the valve. So this may mean that the pump is in too far because you're seeing outflow on both sides of the valve. Now, the tandem heart is a device that you may come across also as well, and we're not going to talk too much about that, but it is a left atrium to aorta flow pump. This requires patients to be, in bed and in a supine position. It is placed by the femoral artery and femoral vein. It requires a transeptal across the atrial septum for left-sided decompression. It is a centrifugal assist device and can provide up to 5 liters of flow. It does have favorable hemodynamic effects, though. It decreases preload through indirect LV unloading. It also increases afterload through retrograde aortic flow, and it causes LV volume, but no real LV pressure unloading. Now moving on to ECMO, which is a device that's becoming increased in utilization across the country, and so it's important to be familiar with some of the things related to this. However, you could spend several lectures just talking about ECMO alone, so we're just going to give you some basics today. So there's two different kinds of ECMO, Veno-Arterial and Veno-Venous, and we're really going to just only talk about Veno-Arterial ECMO today. VA ECMO provides hemodynamic and respiratory support, and it is the most useful tool for acute support for cardiogenic shock or post-arrest, whereas VV ECMO or Veno-Venous is used primarily for pure respiratory failure and does not provide cardiac support. VA ECMO, basically what it does, you extract blood from the right atrium and then you return it to the arterial circulation, and that can be for multiple different ways. It bypasses the heart and lungs. There's a pump and an oxygenator to provide oxygen to the blood and back and circulate the blood in and out of the body. The most common cannulation that you're going to see is peripheral cannulation, and that's here. You have femoral venous and femoral arterial access. Much like this picture, our center does the venous and the arterial on separate sides. But so basically blood is drawn out through this femoral venous cannula to the pump oxygenator and then back via retrograde flow up the descending aorta towards the heart. There's also jugular and carotid cannulation, which I have not personally seen. And then there's also central cannulation, which is direct cannulation of the atria and the ascending aorta for flow. Now, an important thing to consider is actually the retrograde flow and what that means for a patient. So retrograde flow means that you're actually pushing blood back towards the heart. Now, if the heart is not able to eject itself, you're actually increasing the afterload with all of this, and it can cause some mixing of blood that never makes it to the oxygenator because it never leaves the sort of heart circulation, and you can develop sort of mixing of blood towards the aortic root, get something that's called Harlequin syndrome in the upper extremities. So VA ECMO is used in multiple scenarios, again, all of which require acute full cardiac support, right? It's used in post-cardiotomy syndrome, fulminant myocarditis, patients with acute MI, if you're post-cardiac arrest, if you have a lot of ventricular arrhythmia and you need biventricular support. It can actually be used for hypothermia as well to try and rewarm patients. And it's used in anaphylaxis or PE as well as pericardial cardiomyopathy. We also use it in post-heart transplant for a lot of different reasons. It can be used in primary graft dysfunction. It's a very useful tool for that, as well as graft failure. And can be very useful in patients who are being treated for fulminant hemodynamically compromised rejection as well. But almost as important as the indications for ECMO are the contraindications to ECMO. You know, the outcomes of ECMO, unfortunately, are very poor. And so you want to be very careful about who you put on ECMO and making sure that you're not doing something that's kind of futile. I think those folks, you always want to think about sort of what's the bridge. This is a bridge to something. And if someone is not going to be a candidate for that something, then that something could be recovery, that something could be a VAD, that something could be a transplant. But if you're not going to be a candidate, or you think the likelihood of recovery is so low, given the overall situation, then you probably want to, take a second look at whether or not you should put someone on ECMO. So folks who are really old, outcomes are very bad. So if you're over the age of 75, it is a very common, commonly a poor outcome. Active malignancy, again, with a less than 1 year survival, is something to think about as well. Again, not going to be candidates for transplant in that scenario. If you have severe peripheral vascular disease, that's also an issue because you have large cannulas in arterial circulation in the leg typically, and that can cause limb ischemia. End-stage renal disease, if you're on dialysis, again, outcome is very, very poor. Also, outcome is very poor in patients who go on dialysis who are on ECMO. Folks with advanced liver disease, again, because of bleeding issues, can also worsen liver function over time. Patients with intracranial hemorrhage or contraindications to anticoagulation, again, ECMO requires anticoagulation typically due to risk of thromboembolic issues. If you had an unwitnessed arrest and you have ongoing CPR, again, you don't know how long someone was down, you haven't had ROSC, probably not a good idea. Again, outcomes are very poor. Even if you had a witness arrest, but you have been giving CPR for more than 30 minutes and you haven't had ROSC, that's, again, associated with a significantly poor outcome. Anticoagulation in ECMO is varied from center to center, typically used on fractionated heparin with either ACT or PTT goals. Some places may use a direct thrombin inhibitor as well. So you want to target, an ACT of 180 to 210 or a PTT about 1.5 times the normal 50 to 70. Platelet goal of over 50,000. Again, all of these things are sort of balancing the risk of thrombosis and bleeding. So you want to minimize the risk of thrombosis by anticoagulating and maximize the protection against bleeding by keeping platelets up. Also, you want to make sure that you have adequate hemoglobin. This resource said hemoglobin of 12, but in reality, probably not quite so high. But you want to have enough hemoglobin in order to carry oxygen to tissues to prevent ischemia. We typically target a hematocrit of 25 or above. Fibrinogen, again, another thing that can be affected by the pump circuit. And so keeping a fibrinogen over 250 to 300 and transfusing cryo if you need to can help, again, minimize risk of bleeding. But unfortunately, complications and outcomes are poor, and complications are very common in ECMO. Most commonly, we see things like hemolysis, again, because you're pumping blood through a circuit and through an oxygenator. Infections, because you have cannulas that are sticking out the body, as well as bleeding that can lead to an increase in risk of infection. Strokes, cerebral hemorrhage, peripheral cannulation, again, causes issue with limb ischemia. So we monitor patients with tissue Doppler saturation to monitor lower extremity perfusion. We don't sort of routinely put in a peripheral venous, a distal perfusion catheter. Also, some places do. Pulmonary edema, as we talked about, sort of inadequate LV unloading. Again, with the retrograde flow, you actually may have still very high left ventricular pressures and therefore left atrial pressures, and therefore high pressures that are being reflected to the lungs, and you can get pulmonary edema and pulmonary hemorrhage from that. And so you really want to make sure that you're unloading the LV, and there are multiple strategies for that. So first being just simply using inotropic therapy to try and keep the heart from contracting and ejecting some. Also using balloon pumps or Impellas to offload the LV. You can also use an atrial septostomy, which is a quick and easy way to help lower left atrial pressure. And then also direct LV venting that is surgical can be done as well. Survival, unfortunately, is only about 30% to hospital discharge in cardiac shock, in cardiogenic shock and cardiac arrest. Complication rates are very high. This is a meta-analysis from a paper a few years back, looking at sort of overall complication rates based on multiple small studies on ECMO. And you can see that very commonly things like limb ischemia, stroke, other neurologic complications, renal failure, bleeding, tamponade, infection, all very, very common in patients who have been placed on ECMO. And unfortunately, despite all your efforts, many of these patients are not going to survive. If you look at just sort of the indication of cardiac failure, and this is data from the ELSO registry, which was published in 2020, this is the most recent report, that surviving the event of being placed on ECLS or ECMO was about 59%, and then discharge to transfers was 44% in patients with cardiac failure. But in post-arrest or eCPR, it's much worse than that. So only 41% survived the actual event, and then 29% survived discharge or transfer. So unfortunately, a powerful tool, but a very poor outcome in a lot of patients. So in conclusion, temporary mechanical circulatory support devices can provide partial to full hemodynamic support for patients. They help minimize the need for inotropic therapy and improve hemodynamics. Temporary MCS devices can be rapidly deployed in multiple clinical settings, from the cath lab to the ICU to the ER. And understanding common clinical scenarios and troubleshooting these is going to be key to your CCU patient management. So thank you again, and I look forward to answering any of your questions.